All right. Good afternoon, everyone. My name is Stephen Foster. I'm one of the faculty up here in Jonesboro. I'm working with Dr. Clardy today from Fort Smith. We're going to be talking about point of care ultrasound in primary care, kind of an overview about what's going on and how to implement it inside of your practice.
Uh, Actually, Dr. Foster, you can go back one real quick. I would like everyone to join the polev.com link there. We're going to be doing some interactive links as well. So this will be repeated down the line, but if you'll go ahead and join by text with that now, we can go ahead and get that rolling. So go ahead. Neither Dr. Foster or I have any disclosures to admit. We're both forced to do this by UAMS as they write our checks, and we also agreed to do it. So, and we're both kind of active in the POCUS community right now, both learning and teaching point of care ultrasound. So that's our disclosure. Next slide, please. So our main objectives at this time, we're going to become familiar with the basic principles and applications of point of care ultrasound or POCUS in clinical practice. Hopefully some of you have heard this term. It's been in generation for the last 4 or 5 years. And we're trying to bring it to the forefront as a way to deploy technology into areas we wouldn't ordinarily have it, specifically the primary care realm of practice. We're going to kind of talk about the utility of POCUS in real-time diagnosis and management of common medical conditions and the various settings we practice in. And we're going to try and give you some basic skills as far as image acquisition, interpretation, and integration of POCUS findings into your clinical decision-making process. And I am finding personally that it's been very useful in the last number of years as we have expanded our skill set. So here's our first poll. How comfortable are you with point of care ultrasound? And we'll see how this rolls. So if everyone can go ahead and start your responses now. Dr. Foster, do we have a way to see what our denominator data is so we know who's, there we go.
It does not give a direct way, but we can, looks like we're collecting data.
Yeah, there we go. And I have a report from that we're having some issues getting to the poll site from some people at our site. So we may not be getting good data here.
There is a QR code at the top right. That may be an easier way to link to it if you're having issues.
Okay. All right. This is also kind of our first try to get the poll everywhere to work across the state like this. So knowing our audience, it's not surprising at all that we don't have anyone that's very comfortable with point of care ultrasound. And I would say I'm not very comfortable with it either. I'm still learning it. Even though I've been doing ultrasound off and on for about 25 years now, there's always something new to learn in this domain. Do we want to keep going?
I think let's keep going.
Okay. So this is kind of how this works. And this is the dolphin illustration here, kind of looking at the diver and getting the sound reflected back to him. And that's what we're looking at doing here, so that you've got an outgoing beamform and then it returns back. And I kind of think of it like a flashlight. I'm only able to see what my flashlight's looking at. And you have to remember that you can't see anything that's behind it or to the side of it. Same sort of thing with ultrasound. Next slide. And what we're really doing here is we're integrating and letting the computer actually integrate it for us, the sound waves being turned into an image. It's similar to the same software used for CT scan or MRI, where individual bits of data are coming back and being reintegrated into an image that's then interpretable by the operator of the machine. Next slide. So this is going to expose me for the nerd I actually am. So the reality is that the lower the frequency, the further it's going to go. And so, I've got the elephant there, and people may or may not realize elephants can communicate using infrasound at frequencies below what we can actually hear. Most humans can hear between 20 and 20,000 kilohertz when they're young, and as they get older, to drop, those frequencies start going down. You hear about between 20 hertz to about 10 kilohertz by the time you're about my age. As far as the infrasound is concerned, elephants will communicate over miles and miles of territory using sound we can't even hear. When you move out to ultrasound, you've got bats that are using echolocation to find prey when they're flying and to avoid obstacles, but that's a very short range kind of phenomenon, and so it only functions within a few feet. And so what I really want you to take away from this is that the lower the frequency, the further you can go, but the higher the frequency, the more resolution you're going to get. So there's a trade-off in both directions. Next slide. So what is actually POCUS? What are we actually using it for? So it's basically a quick abbreviated study performed and interpreted immediately by the person at the bedside, and you're trying to answer clinically impactful questions. And so the idea of POCUS, and what I think probably makes a lot of people afraid, is you're not trying to generate a full radiology report. You're trying to answer one question, okay? Like on the FAST or the EFAST scan, is there fluid somewhere in the abdomen? For AAA, is a AAA present? You're not trying to generate a detailed retroperitoneal scan report. You're just trying to determine if there's a AAA present or not. Is there a pneumothorax? Is there pulmonary edema? That's the question. There are some procedural things we do. Central line insertion is one of them. Musculoskeletal and joint injections is another. And again, you're just looking at something very specific. For focused cardiac ultrasound, you might be asking a question like, what is their ejection fraction? Not within a percentage point, but like, is it normal? Is it high? Is it normal, or is it low? And if you can get that kind of data, that can give you some clinically meaningful data that's going to impact what you're doing with that patient at that moment. Okay. And I've had twice in the last 2 months opportunity to look and do scrotal or testicular assessments looking for blood flow. And that's very reassuring when you can compare two testes, one painful and one not, and determine they both have the same blood flow. And you're not dealing with a torsion at that point. So that's great. Now, the other half of this is just because you do POCUS and you answer a question quickly, that doesn't mean you don't follow up on it. So for example, if I do a DVT scan, what I really care about is the location of a DVT between the knee and the groin, because that's what needs to be potentially hospitalized or intervened aggressively. It doesn't mean that someone with a lower extremity that's swollen doesn't need further follow-up. You haven't ruled it out completely. You just ruled it out between the knee and the groin, which is what's clinically significant. At that point, you'd want to follow it up with another scan, but your urgency is reduced somewhat at that point. So, next slide. We have a variety of transducers we're going to use, and you notice that there's numbers on all of those. Well, those correspond to frequencies, and so you've got a 3 megahertz probe there. You've got a 12 megahertz probe. There's a 4 curvilinear probe there. And remember what I said earlier about the higher the frequency, the closer the distance is going to be. Well, that's what you're getting here. So you've got that straight probe there, that 12L. That's going to be an MSK probe or skin and soft tissue probe. And that's going to give you data of stuff that's up close. You're not going to be able to see very far in. If you look at that curvilinear probe right there, that's an abdominal probe, one we frequently use for obstetrics. You can see almost all the way to the table underneath the patient with that, because it's a much lower frequency probe. That's a 4 megahertz probe versus the 12 megahertz probe. So, and then there's some other issues with probes that we don't necessarily need to get into in terms of, are they cardiac or not, and are they better at determining motion? And I think it's probably beyond the scope of this particular program. You'll see there's that linear probe, that L8 to 18. That's a tunable probe that will do multiple frequencies right there. So that's a pretty versatile probe there. Next slide. So when we talk about image optimization, this is kind of what was going on before. So if you'll notice our illustration there with the high frequency probe, You have a shorter wavelength, shorter penetration, and good resolution. So if you're trying to find a foreign body near the surface of someone's skin, for example, the BB I pulled out of a kid a year ago, this was great for that. However, if I used a low frequency probe for that, I would be able to see pretty deep, but I'd have poor resolution. I wouldn't have a good idea of where things were. And you'll notice the way those illustrations are, the structures are the same, but the images are different. And that's what you need to kind of understand there. Again, higher frequency has shorter penetration and low frequency has a longer penetration. So low frequency goes further. Next slide. And this is a better illustration of that as well. We can also equalize our image somewhat. And this is a software issue where it changes the gain response to the deeper structures. You'll see in illustration A, you've got signal loss away from the transducer. You up the gain in that on the graphic equalizer on a big machine, and on the smaller machines, you've got kind of an automated equalization that'll kind of optimize your image for you. Signal near the transducer remains the same in that case, but in your deeper tissues are amplified and you get a more uniform image quality. And here you can see we've got some liver that we're looking at here. Next slide. As far as the gain, the new person doing ultrasound has a tendency to turn the gain up in order to see better. They're trying to turn the lights up a little bit more, but the problem is that's going to obscure some of your structures. So you've got the low gain setting there where you can't see very well. You've got the high gain setting where you feel like you're seeing more, but you actually aren't. And you will notice you've got more detail when you have things kind of in the middle. So it's a little bit of a Goldilocks kind of phenomenon. You know, there's too much, not enough, and then just right. And you're going for just right. Most of the modern equipment that's being deployed now is going to have an automated gain feature that will adjust these images for you using a computer algorithm to give you the best image for interpretation. But in the event you don't have that, you need to be willing to turn things up or down in order to get the best image. And the reality is the more you do this, the more you find yourself fiddling with the image quality more than actually looking at the images in order to get the best one. You're tuning the machine in order to get your best interpretable image. Next slide.
All right, so we kind of thought one of the best ways to learn how to do point of care ultrasound or POCUS is to actually see what it's like in practice. And so I feel like for me, and most people agree, the DVT scan is actually one of the easiest scans you can do because all the vessels are close to the surface, the anatomy makes relative sense, and things are easy to identify. So on the DVT scan, you actually start way up, all the way at the top of the groin, right where the great saphenous vein joins into the femoral vein, and you start working your way down, scanning every typically 2 to 3 inches all the way down to right below the knee. This is the majority of the time where your deep vein thromboses form, and this is usually the high-risk area. This scan, once you're experienced, usually about 25 to 50 scans, usually takes less than about 10 minutes to perform. So it's really quick. You can do it in clinic and actually rule things out. So on the left over here, we're actually going to see what it looks like, and we'll kind of walk through. So you'll see artery is going to be right here, and then this is going to be the vein. And so what they're doing is you put the probe on the skin, get the vessels, and then you're going to compress the skin down with the probe to look for compression. Artery should stay open, veins should compress all the way down, just like right here, and close all the way. That is a normal scan without a DVT present. On the other hand over here, we have the artery that's pulsatile right here, and if you notice, this vein does not close all the way down, and there's some echogenetic or abnormal colors inside of the vein itself. If you start seeing this is what a blood clot will look like. You can actually put flow on it that will actually show if there's blood flow around it, kind of showing that there's blood there, but it's stopped or it's traveling in the wrong direction. And so what you'll do is you'll find this, you'll scan, you go up and down, and this will kind of imply that there's a blood clot there. So our next question is going to be, you have a 43-year-old female that came in with complaints of unilateral leg swelling times 2 days, and then this is your ultrasound. So skin is going to be at the top of the image and deep vessels below. So take a look at it. And this is Doppler flow right there. So we'll play it one more time for you. All right. And then here is your next question. So based on that, what is your interpretation of the image you just saw? And we'll give you guys just a few seconds to answer. Maybe about 5 more seconds. All right, so the correct answer here is actually it's going to be lymph node. It's a false positive DVT scan. So like we talked about before, one of the important things with point of care ultrasound scans is you know exactly what you're looking for and what you'll see. So we'll go back and we'll look at the scan again. So over here is actually going to be your vessel on the very left-hand side of this image, as you see the blood flow right there. This is actually an enlarged lymph node, which is what this color Doppler is showing. If it was a vessel with a DVT, you'd actually see the color flow around it with that clot in the middle.
I got this wrong too at our run through, so don't y'all feel bad about that. It also helps to know where your hand is on the scanner. That's one of the things that I've discovered is that it's not just the images, it's the integration of the image in your brain with your hand on the scanner, knowing where stuff is and what you're looking at, that really brings the whole thing together in the, as far as the POCUS evaluation.
All right. So we've now gone from one of the easier scans, which is the deep vein thrombosis, all the way to one of the more complex scans, which is actually the point of care echocardiogram. So as we kind of alluded to before, these are asking general but specific questions. For instance, is the ejection fraction normal, increased, or decreased? Is there pericardial effusion? Is there appropriate heart squeeze? And is there right ventricular failure? We are not looking for specific percentages. We are not looking for aortic root measurements. We're just looking at general, is it normal or abnormal? And then basing our medical decision-making on that assessment. So there are 4 views involved in the cardiac exam. Parasternal short and parasternal long are on the left side of the chest at the top here. Basically, you're cutting through 2 different views of the heart. Then you have the apical 4 chamber, which is the best position to look at how the heart is beating overall. You see all 4 chambers there. And then you have the subxiphoid, which is usually used primarily to look for fluid around the heart. It has a great window because you're looking through the liver. And so it gives you a lot of detail about what's happening around the heart. As far as evidence for using POCUS for echocardiogram, a lot of the studies come out of the emergency department. As most people are probably aware, the ED has already integrated ultrasound into their residency training. And every one of their residents will graduate with POCUS criteria met to do practice in the real world. And so what all the studies have found that when they looked at all these things, that the emergency department physicians were just as capable of determining the questions we talked about as their cardiology colleagues in formal ultrasounds. Now, like we said, we're looking at very specific details, not the entire radiology report, but it shows there's evidence for doing these scans in real time. So one of the first scans we look at is going to be the parasternal long. So this is cutting through the heart. And so like we talked about, the first question is what is the ejection fraction? So just to make sure that everybody is on the right page, this chamber right down here, if you can see our mouse at the bottom of the screen, is the left atrium. The left ventricle is the large chamber. This is going to be the aortic root right here, and then the right ventricle is going to be over here. And so what we're looking for is we're looking to see if the heart squeezes and decreases symmetrically all the way around about 50%. And then you assess valvular function. If you look at the valve right here, we're looking to make sure that it slaps the wall on either side. That is generally a pretty good indicator that the ejection fraction is normal. On the right side over here, we see an abnormal heart. And so as you can see, the valves are barely opening at all. The left atrium is enlarged compared to the aorta of the right atrium. And then the left ventricle is barely squeezing at all. So this is going to be a reduced ejection fraction, suggesting a patient has heart failure if you're going on and doing a scan. Same thing with the parasternal short. Now we're cutting straight through the heart. Right ventricle over here, or sorry, scratch that. Left ventricle over here, right ventricle over here, and we're looking for the same thing. Is the heart squeezing equally all the way around? Do the valves look like they're working well? And then you're just comparing left to right as well. And then over here, this is an abnormal reduced ejection fraction. As you can see, the heart is just not squeezing well at all, and the valves are not opening all the way up. So this would suggest that the ejection fraction is again reduced and there's something going on in the heart. And finally, we're going to look, our next one is going to be the apical 4 chamber. This is actually below the nipple line on the left-hand side. And so the top or the skin is right here at the top of the image. You're looking through left ventricle over here, right ventricle over here, left atrium, right atrium, and you're looking for similar things. Is the heart squeezing equally? Is the left side of the heart bigger or equivalent to the right side of the heart? And do the atria look equal? And then how does the squeeze look? And then on the right-hand side over here, you see how the left side of the heart is significantly larger. The valves are opening, but they're not slapping the walls like they're supposed to. And you compare left to right, the left side of the heart's valves are reduced. The right side is actually opening up correctly. So this would suggest there's some left-sided heart failure or reduced ejection fraction.
Before we leave this slide, it's something I'd like to point out. You'll notice there's the P at the top of that image on the right. That actually tells you where your probe marker is. And if you will notice on some of the other images, it's always on the other side. The cardiac standard is for it to be reversed, which is probably why cardiac ultrasound is my kryptonite. I have a lot of trouble with it, getting the visualization right, because I've been doing ultrasound so long for other things. And so that is one thing to realize, is that for cardiac standard, the probe orientation is reversed. So I just wanted to kind of point that out real quick.
And then finally is the subxiphoid. So in this case, you're actually up underneath the xiphoid in the center of the chest, and you're shining, typically have the probe pointed from the right side to the left to look at the heart. And so here you're generally looking at overall structure. So this bright line around the edge right here is the pericardium, and you're looking to make sure that it stays right around the heart. There's no black space there. And then you're just looking to see, does the heart appear to be squeezing appropriately? Is there anything grossly normal? So in this case, it is normal. The pericardium is right there. There's no fluid around it. Everything else looks good. On the right-hand side, you'll see the heart beating right here. This image is actually better because this black space right here is fluid around the heart. And so because ultrasounds travel better in water, it increases the image quality because there's more water there for the sound to travel through. And so you do the same thing. Do the valves look like they're functioning? This one actually looks like it's not quite hitting the wall. And that left ventricle is not squeezing appropriately all the way around. Look at the right ventricle or the left atrium over here. It is large. But the right side is still intact. So I'm going to let just play one more time because this is going to be our next question. All right. So based on this image right here and the effusion, is cardiac tamponade present? We'll give just a few more seconds to get the last answers coming in. We're still seeing some more answers coming in. So. So the correct answer is actually no. There is no cardiac tamponade present. So as we talked about before, we see the fluid all the way around the heart. But the most sensitive and specific signs for cardiac tamponade in ultrasound is actually whether or not the atria and the ventricle are still functioning. The most specific is that the right ventricle is not going to open. It's not going to move. It's going to be compressed shut. That means that the pressure around the heart from the fluid is too great that it's causing right-sided failure. But in this case, you can see that there's still movement. It's still beating. Same with the right ventricle, it's still open, there's still blood flow there. So while there is a significant amount of fluid around the heart, there is no cardiac tamponade. So this patient can most likely will not require paracentesis, will not require removal from the fluid around the heart right now. Sorry, words are hard. And so in this case, you can probably diurese and kind of go from there and have cardiology manage. So this is where it's important to know what you're looking for to better manage patients. So going back to what we talked about earlier, our last question on the cardiac area is, which of the following is not considered part of the cardiac focus point of care ultrasound? All right, so the correct answer here is actually the aortic valve area. So the ejection fraction, while we don't want a specific number, we're looking for normal versus abnormal. Is it decreased? Is it normal? Is it increased? Right heart strain is kind of like we talked about. Is the right side of the heart less than or equal to the left side of the heart? That's how you kind of assess for strain. IVC collapsibility is usually a yes or no question. So when you're looking, you see the ejection fraction is reduced. Does the IVC appropriately collapse with inspiration? Pericardial effusion, we talked about, everybody got present or not. That's the only question. But the aortic valve area is a very specific question that will fall outside of the POCUS examination. A lot of the times that's used in formal ultrasounds, but as far as clinical management in the immediate decision-making process, there's not really an application for that. All right, so now we're going to transition a little bit and we're going to go talk about lung sliding. So here we're looking at the pleural lining of the lungs to see if the lungs are still functioning correctly. And so we'll look at normal first on the left. And if you guys can see that bright white line in the middle, this is called an ants on a log effect. So as you kind of see, it's a shimmering line there. It looks like it's moving. This means that the lung is sliding appropriately against the chest wall. So up here, the two circular structures you see are the ribs, the skin is at the top, and so there's good sliding happening right there. This suggests that the lungs are functioning correctly. On the right-hand side, you see that same white line, but there's no movement. So this is a very sensitive sign for there being a pneumothorax present in this patient. And so the interesting thing with point of care ultrasound or ultrasounds, you can actually look and find a specific point where the pneumothorax begins. So you'll see sliding on one side, and all of a sudden it'll stop and there'll be no movement on the other. And that is called the lung point, and that is where the pneumothorax begins. So this is a really quick scan. Patient comes in with shortness of breath to go, hey, is there pneumothorax or is there something else going? Okay. In lungs, when you're looking grossly at lungs, there are two big questions that you ask. The first one is, are the lungs full of air or are they full of fluid? So on the left-hand side of the screen here, you see these bright linear lines that run across the screen. Those are called A lines, and that is the interference from the ultrasound signals traveling through the air and bouncing back when it bounces off tissue. The dark shadows that you see pointing down from the screen, those are the ribs that you're looking at that block all the imaging behind it. But this is a completely normal lung. So you see those linear lines all the way down. That means that there's air there and things are functioning correctly. On the right-hand side, if the lungs are full of fluid, you'll see what they call B lines. And so the B lines are those really bright beams of light that travel all the way down to the bottom of the screen. For it to be positive fluid, there has to be greater than 3 lines that travel at least 20 centimeters down the screen. So usually what we tell people when we're working on this is if you see lines all the way to the bottom of your curvilinear probe, you have fluid in the lungs. And so this is a really easy way to put an ultrasound on there and go, hey, is there air where there's supposed to be, or is there fluid? So think about CHF exacerbations that come in. This is a great quick test to see what's going on. All right, so our next question is going to be a 43-year-old male presented to the emergency department after being involved in a motor vehicle collision. Skin is at the top of the picture. This is the pleural lining right here. And so we're going to run and see what we see. Play it one more time. All right. So based on that ultrasound, what is your interpretation of the results? Is it normal? Was there a pleural effusion present? Is there cellulitis present, subcutaneous emphysema, or none of the above? And I'll go back one more time just so everybody can take another look now they have the answers on their phone. Okay, just a few more seconds. So the answer to this one is actually subcutaneous emphysema. So what I think the pleural effusion, you see these lines right here. So you do see some lines there, but if you notice, we are really close to the surface of the skin. And so while there are some lines there, it's not more than 3, and we cannot say for sure that they're traveling all the way down 20 centimeters. But one of the first lessons I learned in performing ultrasound is that if the image looks bad, there's probably air interfering. So if you notice up here how there's a bunch of interference, and there's some black pockets, and there's just a bunch of scattered light, that is all emphysema or air trapped underneath the skin that's causing interference with the ultrasound.
And then one of the things I'd like to point out, if you look on the right side of that image, you see the lines there, that 1, 2, 3, that's centimeters of depth. And so this is a pretty shallow image. And so that'll also give you a clue if you're having to review another image that'll tell you how deep the probe's actually going. And that green arrow is the focal length. And so it's focusing on that particular band right there.
All right. So one of the bread and butter applications of POCUS is actually the FAST examination. This is the assessment that we do in emergency departments when patients come in after being involved in a trauma. So focal assessment of sonographic trauma. And basically, we're going to look at the clinical questions, the relevant windows, and then whether it's normal or abnormal. These are really quick scans designed to take usually about 30 to 60 seconds to complete in each area, but it gives you a lot of information about management. So the 2 primary questions that you're going to ask is there fluid in the abdomen or pelvis? And is there fluid in the pericardium? That is the only thing we care about in the scans. Everything else is secondary to those two questions. So typically for these scans, you'll either use the phased array or the curvilinear probe. These give you a lot of depth and give you enough detail to see what's going on. There are 4 areas you're going to look at. The first one is what Morison's pouch, or the hepatorenal side on the right-hand side, right upper quadrant. Subcostal when you're looking up into the heart. Parasplenic on the left, and then suprapubic when you're looking at the bladder. Okay. Hepatorenal, basically you're looking at a longitudinal plane, you're looking at the axillary line, and then you're looking between the 7th and 9th rib space. So on the image right here, the big, on the left-hand side of the image is the liver. So you're shining through the liver and looking at the kidney, which is that oval structure on the right. And then what you're looking for is you're looking for fluid. Sorry, it's hailing here right now. Looking for fluid between the liver and the kidney. So fluid's going to show up black, just like the red lines right here. And that's going to be a positive sign if you see that strap of fluid there. Parasplenic, same thing. Posterior mid-axillary line, what we normally tell people is you're going to reach across the patient, and then your knuckles are going to touch the bed with the ultrasound pointing backwards. 5th to 7th intercostal space. Spleen is on the left-hand side of the image. Kidney is on the right. And this is a normal scan. There's no black fluid or anything else. So this is kind of what the scan is going to look like. It's going to be quick. Kidneys up here, and if you notice, there's fluid around right here. This is a positive scan. Or sorry, spleen, kidney right here. There's no fluid. On the right-hand side is going to be the positive where you had that stripe. Black pockets are bad and usually need fluid. Next, you're going to have the suprapubic scan. This is going to look transverse, low in the pelvis, looking for fluid behind the bladder. And so it's going to look at this. You're going to shine the black, go to the pubic bone, put the probe right on top of it, and shine back underneath it. And you're going to see this cross section right here. Bladder's right here. In a female patient, you're also going to see the uterus, depending on their status. It can look like there's fluid there, but you're going to look for that uterine stripe right in the middle is usually the big sign. And then on males, you're going to see the same thing, but you're going to see a prostate at the bottom. These are normal images. Then you're going to rotate the probe 90 degrees. You're going to look at the longitudinal view. And this is actually the better view to look for fluid. And you're going to scan from one side of the bladder all the way to the other. As you can see here, normal scan. So this is an abnormal. So what you're looking for, bladder's right here. There's some stuff in the bladder, which is usually a bad sign. You can see those bubbles kind of floating there. And then right through here is going to be that abnormal strap of fluid. That's kind of the FAST exam, relatively quick. We already talked about the cardiac, so we left the subxiphoid view off, but that's what you're looking for. Finally, we're going to come and just kind of do an overview of joint injections. Most of the physicians that I know generally use landmark-based, which is usually adequate to get pain control. However, there are studies out there, and the majority of them agree, that the sensitivity and specificity for getting in the correct location, actually getting in the joint space, is approaching 97 to 98% with ultrasound and about 60% with landmark. Well, pain control is generally close to the same, especially if you're looking for aspiration. This is much more accurate, and patients actually enjoy it because it gives real-time feedback to see what's going on. So the 2 examples here, the first one is the knee. So you're going to put the probe across the top of the knee, and then you're going to shine it on the patella right here, femur right here, and you're looking for joint space to open up between the two. If there's an effusion present, it'll be a large space like that. If there's not, it'll just be a thin line that's present right below the tendon. You'll take the needle, run it through from the side, you'll hit the joint space, and then you can either aspirate fluid out or inject your corticosteroids in. And if you aspirate it out under ultrasound guidance, you'll actually see the fluid move in real time, and patients generally really appreciate that view because it lets them see what's happening. On the other side over here is a shoulder injection. Shoulders are very complex. There's multiple ways to inject. This is becoming the preferred way that I do now, where we actually lay the patient down and inject into the shoulder. Same kind of thing, ultrasound over, you're looking for the biceps tendons. You're going to look for any joint space that runs around there. You'll find the joint space and you'll follow the needle all the way into the joint space. And you will aspirate or inject your steroids. Patients, like I said, enjoy it. Much more accurate and precise. And then go from there. Anything can be done on ultrasound. We've done trigger injections under ultrasound. It's a great way to get comfortable with ultrasound using landmark bases as your basis.
It also is a great way to get your small joints done. So if you're trying to get like an AC joint done, doing it under ultrasound is a great way of making sure you get into that tiny joint space. Thumb base is good. And then the small joints in the foot, if you're going to do a steroid injection for gout or something like that, which has some indications there. And it's great to be able to see what you're doing there.
Right. I was going to kind of sum things up. One of the best things about point of care ultrasound is it is available to everybody. Scanners now, the ultrasound device themselves are under a couple of $1,000s a piece. You don't have to be an expert. It's great to kind of start to pick up. You have a patient in clinic with a complaint of knee pain, put the ultrasound on there, look up the anatomy, and you can generally teach yourself how to do it. And the other important thing is there are a lot of resources that are out there. There are several that do full fellowships, or you can do part-time fellowships that do hands-on training. There are a lot of courses you can take and YouTube videos that kind of walk through how to get the joint injections done. So it's a great skill to pick up in clinic. Insurance reimburses at a higher rate. I think for the last time we looked at injections, it's usually $60 to $120, depending on insurance, for an injection over just a landmark based. And so it's a great way to increase skill, add benefits to your patients, increase their satisfaction, as well as generate a little more revenue for you. So with that being said, are there any questions? So to answer the question, what would be the next step if cardiac tamponade was present when you completed a scan? That would be depending on your level of training and what you have approval to do, but that would be where you need to do the pericardiocentesis. Somebody will have to do it. So it'll either be going to CV surgery, cardiology. Somebody will have to go in there, drain the fluid out of the heart to get the patient stabilized. And a lot of the times, if you're doing the scan working in the emergency department in most of our state, it's probably going to be you because there's going to be nobody to back you up.
So there's the question, what specific courses did you get training at, or any of you, or do either of us recommend where we are that are live? We, through a grant that was given to the state about 2-3 years ago, were given access to the Global Ultrasound Institute courses, and that was actually a very good course. I've been to one of them. We've been participating in a fellowship as well to get more experience, but the biggest problem with the live courses is you learn a ton and you're really good for about 24 hours after that, and then it's a perishable skill, and if you don't continue to do it, you're going to lose it. So the best thing to do is that once you get those skills is to use them all the time. The best way to learn ultrasound is to do ultrasound and to do it wrong, and then learn how to do it right. And that's the best advice I can give there. So
Yeah, it's the Global Ultrasound Institute, GUSI, GUSI.
And they have a pretty robust website and a good schedule. And if you sign up on their website, you'll get email every 3 or 4 days.
The other thing I'll recommend, if you go to any national conferences, whether it's Society for the Teachers of Family Medicine, FMX, any of AFB's conferences, they actually offer usually a pre-conference workshop dealing with some part of POCUS scanning. And that's a great way to kind of get your skills up. I'll echo what Dr. Clardy said. I now, when I'm in clinic, have the ultrasound set up ready to go because the less barriers to using it, the more likely I am to do it. And so I take advantage. I set it up in clinic when I'm down there. And then usually once or twice at clinic, if something comes in, I'm like, okay, let's scan it real quick and let's see what's going on.
And then another source for live education, I did the course for it's the Procedures Institute, the one people that work out of Texas. I'm trying to remember the full name of that. They have a number of different procedural courses, but they had a course done, and actually it was done by Grant Fowler, the guy that authored the Procedures for Primary Care. That was a great course. And then I've done the fetal echo courses a couple times just because I do a lot of obstetrical ultrasound, and those are also excellent courses for someone's looking for more advanced training in something specific. There's a question, are we saving clips in a centralized location? We are not. I don't know about y'all's clinic.
We are not currently. We are working towards that area as an institution, but a lot of the times we're saving them locally. And the advantage of saving images locally for you too is that many institutions require certain numbers of images for credentialing, and so it's a great way to have your own private stats of images to say, hey, these are my scans that I've done. This is what I want to do to apply for credentialing.
The other big issue is I actually counted it up recently. I have 6 different ultrasound platforms in our building. I can't even get one of them to talk to Central. So it's not technically feasible at this point in time. You have to have some sort of image retention and recall in case you get audited if you're going to be billing for it. You have to generate a report as well, but the POCUS reports are different from full ultrasound reports. So that's kind of beyond the scope of this particular talk, but there's lots of standards available that are easily found on the internet. All right, that looks like that's all of the questions. Yes, that was Fowler's Procedures for Primary Care, Grant Fowler. And he actually hosted that particular class I went to. And it was great. He's kind of he's one of the heroes in my pantheon. And it was cool to be able to do a course with him. And at the last conference up in Kansas City, I got a selfie with him. So that was kind of fun. I was a big old fanboy there for a little bit. So anyway, thank you everybody for your attention today. I've appreciated it, and I would like to give the majority of the credit for today's presentation to Dr. Foster. He kind of ran with the ball on this, and I more just ran interference. So
It was a group effort. Thank you guys.
Mm-hmm.